Hi everyone, welcome to the webinar of the Health Economics alongside Charles Special Interest Group HISIC, presented by Associate Professor Ching Lee today. My name is Nhung Nghiêm. I'm a health economist. I'm a health economist by John Cotton School of Medical Research at the Australian National University in Canberra. I'm the co-chair with Lisa of the HISIC. So we acknowledge the traditional custodians of the lands on which we live, work, and meet today, and pay our respect to their either past, present, and emerging. We extend that respect to Aboriginals and Torres Strait Islander people here with us today. Just some welcome and housekeeping. Please ensure that your microphone is on mute. And please use the chat function or raise your hand to ask any question at the end of the presentation. So Ching Lee, would you like to leave all the question at the end of the presentation, right?
I'm happy for burning questions during the presentation as well.
And perhaps if people can just put questions in the chat, because Nhung and I will monitor the chat because it will be very hard for Jing to see people while presenting on her screen, and also to be able to see the chat. So we'll monitor the chat. So if you have questions, just pop them in the chat, and we can read them out as needed during the presentation or come to them at the end.
Okay, thanks Ching and Lisa. And the recording of the webinar will be available to watch on the ACTA website and the YouTube channels. And we also appreciate your completing the post webinar survey so that we can have idea for the next webinars. So our speaker today is Ching Lee. She is an associate professor at the Center for Health Economics, Monash University Business School. She leads the Monash Health Technology Assessment teams, conducting evaluation that inform funding decisions for health technology globally, including the Pharmaceutical Benefits Advisory Committee, PBACS, Medical Service Advisory Committee, MSACS, and the Australian technical advisory groups on immunizations, and also the Agency for Care Effectiveness in Singapore. Her research focused on healthcare decision-making, cancer care, cost-effectiveness analysis alongside clinical trials, and also advanced decision analytics modeling. So welcome, Ching.
Thank you. Okay. So I would like to just start my slideshow. Just give me a second to get that going. Okay. Can you all see my slide?
Yeah, that's perfect.
Awesome. Okay. All right. So thanks so much, ACTA, for the invitation to present today. This is a recent piece of work recently published in Social Science and Medicine on the social value of a childhood QALY, revealed preferences from pharmaceutical funding decisions in Australia 2005 to 2023. The work is in collaboration with a big group of authors located across Deakin, ANU, University of Sydney, Glasgow Caledonian University and Oxford, and it was part of a bigger project called TORCH, Tools for Outcomes Research to Measure and Value Child Health. So why do we do this research? So the motivation is that we know from data preference literature, including recent systematic review published by Peasgood 2024 and Lancer et al. In 2020, that indicate there's great public support for giving greater weight to identical health gains in children versus adults. And health technology assessment bodies or agencies also explicitly weight aspects of equity in addition to health gains in HTA decisions. These include need, potential years of life lost, etc. Now, age is informally considered. To our knowledge, no agency apply any explicit weights. So the Australian Pharmaceutical Benefits Advisory Committee, or the PBAC, they make recommendations on drug funding in Australia. And being a small country, we've actually led the world in requiring economic evidence in all health technology assessment submissions. and hence beginning rational decision making and accumulating over 30 years of reveal preferences for study. So I guess the question we wanted to ask was, do reveal preferences for child versus adult drugs in Pharmaceutical Benefits Advisory Committee PBAC decisions mirror the findings from stated preference literature? And I guess the novelty of this particular topic is age hadn't really been studied in any previous reveal preference studies for PBAC decision making. So how do we go about doing the study? We first constructed a data set of evidence presented to the Australian Pharmaceutical Benefits Advisory Committee from their public summary documents. They are known as PSDs. And from those documents, we extracted data on the PBAC's views on the evidence for all submissions July 2005 to May 2023. That was 2,392 records. At the time of our study and the data extraction, that was all the records that was publicly available, and we did the data extraction following a predefined template. Then from that, we identify submissions for child only or child plus adult versus the adult populations. And then finally, we econometrically tested whether interventions affecting children were more likely to be recommended for public subsidy compared to interventions for adults, whilst controlling for other factors that may impact decisions. So you might ask how we identified interventions for kids and adults and kids plus adult populations. And we did that by screening, obviously, the public summary documents. We screened all the records for keywords: child, less than 18 years, adolescents, infant, ped or ped, depending on what kind of, whether it's American English or UK English, and all records were screened. From these, 1,678 were considered adult only, and then we did a detailed screen for the remaining 714 and further excluded 191 from that screen, and then the remaining records, 523, including 174 child only indications and 349 records for child plus adult indications. So our data extraction, I guess a little bit about the demographics of the type of things we've looked at. Our data extraction included all types of submissions to the PBAC, including those presenting a cost minimisation analysis, where the clinical claim for the drug in question is non-inferiority in clinical efficacy or safety versus the comparator, and the economic analysis to make sure that the new drug will not cost more than the existing treatments. There are also cost utility type submissions where the submission does not make, they do make a superiority claim for either efficacy or safety versus the comparator, and modelling is presented to estimate an incremental cost-effective ratio, or ISA for short, expresses either cost per additional quality adjusted life years gained, so that's a cost utility. Other types of analysis could be cost-effective analysis, where the benefit expressed as a cost per additional health benefit. So, for example, cost per additional responder, or a cost analysis where the analysis compared cost only but not benefits. In some cases, no economic evaluations are presented, and in one case, a cost-benefit analysis was presented where the health benefit was translating into dollar terms. So I guess you can see from the descriptive stats that are included here, the majority of the submissions were either a cost minimisation or a cost utility analysis. For our analysis, because we need to express the outcome in the same units, we only included submissions with either a cost minimisation or cost utility analysis. For the cost minimisation analysis, we also imputed incremental cost-effective ratios as 0, given these submissions were on the basis of no meaningful differences in clinical efficacy or safety and no additional costs. Okay, so I guess I'm emphasising the box there where the submissions included. Okay, so here's a summary of the cost minimisation and cost utility submissions by population type. So you can roughly see 50-50 for the two types of economic evaluations, and a very, I guess, a relatively small sample size of child-only submissions in both. Okay, so in our econometric analysis, the independent predictor of interest is the population. That is, whether it's a child or child plus adult or an adult population. And we want to know, I guess, the influence of the population on receiving a positive PBAC recommendation whilst controlling for other attributes known to be important to PBAC decision making, including whether the PBAC considered there to be considerable uncertainty in the clinical data, whether the PBAC considered the benefit to be clinically meaningful, and whether there was uncertainty in the economic modelling. The incremental cost-effective ratio, or the ISA, is coded as a categorical variable in the public summary documents. It's an indication of the value for money of the drug, and also lastly the budget impact, whether it's likely to cost the PBAC more than $10 million a year, or how much it's going to cost the PBAC. So these controls were informed by previous work we have published in this area and would have been demonstrated in previous analysis to be important factors on the likelihood that a drug will receive a positive recommendation from the PBAC. Okay, so for example, for one of the controls, the incremental cost-effective ratio, this graph demonstrates a good spread of the child plus adult indications in all ISA categories, from cost min less than 15K to up to 200K per QALY. Only when you get into the more than 200K per QALY gained category, there appear to be a higher proportion of submissions for children, child plus adult versus adult only. However, naturally, there's much fewer submissions in that ISA band. Okay, so our dependent variable in the econometric analysis is the PBAC's recommendation. Now, the PBAC can make recommendations to not recommend the drug, or recommend that the drug be listed at the price requested. They can say, we would like to list with some additional criteria that the submission themselves did not propose. For example, it could request a risk sharing arrangement or a managed access scheme. Or it could say list similar in class, meaning they didn't believe the superiority claim and a cost minimization versus a listed drug as recommended instead. Or they can say list at a lower price. So some decisions are also deferred because, for example, the PBAC cannot recommend if there's no TGA approval at the time of the PBAC consideration. Or the PBAC could simply be asked to provide some advice, and that was not to do with listing. So in our primary analysis, we have included submissions where this recommendation could be unambiguously linked to the submitted ISA. So list at the price requested or reject. And in sensitivity analysis, we also included and treat list with criteria as a positive recommendation, given the difficulty of differentiating this this outcome from list at price requested based on the retrospective data that we looked at. Okay, so in the primary analysis, this meant we ended up with 1,244 decisions, whereas in the sensitivity analysis, we have 1,434 decisions. So I guess you could see, even in the raw descriptive stats, there was a higher proportion of yeses in the child only and the child plus adult categories versus adult only. Yeah, so another really important objective of our paper is to consider whether the priority given to paediatric interventions can be explained by broader equity concerns. To that end, we've looked at prevention versus cure, identify whether the drug is identified by whether the drug is a vaccine, severity, unmet need, and rarity, which is represented by TGA orphan drug status, and alternatively the FDA's designation of accelerated access provided based on surrogate outcomes for treatments of severe conditions with unmet need. And lastly, we also looked at bodily functions affected by the treatment as per the WHO anatomical therapeutic chemical classification of each drug, or commonly known as the ATC code. And you can see the descriptive stats for those, and there's slight differences across each of the populations. Okay, so in terms of the analysis, we applied a logistic regression because it really fits the data and is easily interpretable. So for our primary analysis results, that's shown here, together with the predictive average marginal effects. So you can see submissions for obviously the population effects are highlighted in red at the top. Submissions for child has a statistically significant higher odds of being recommended for listing compared to submissions for adults, corresponding to approximately a 16 percentage point increase in the probability of a listing recommendation. Now, while the odds of a positive recommendation are also higher for child plus adult populations, this is not significant at the 5% significance level. Now, all other controls were statistically significant with the expected direction of effect, except for interaction between clinical important effect and cost utility analysis. The factor with the biggest effect the lights in my room's gone off, on a positive PBAC recommendation was actually considerable economic uncertainty. So it's an average 43 percentage point reduction on the probability of a positive recommendation. Increases in ISA and also increase in the expected budget or associated with reducing odd of being recommended. The effect of the ISA 45 to 75K compared to those less than 15K is almost the same magnitude but opposite in direction to that of the effect of child. And I guess this is, for those who like a picture, anything that clears the red line, with the whiskers clearing the red line, is significant at the 5% level, and those on the right-hand side improve your chance of being recommended, and those on the left-hand side reduce your chance of being recommended. So it's saying the same thing that I've just presented before. Okay, so I did mention that we did a lot of sensitivity analysis to try to remove the effect of the child and see if it's actually, because there's lots of things, it's collinear potentially with the age effect. So here's one of those, several, actually not one, there's 8 of those. The supplementary analysis try to look at those additional equity factors, such as severity, unmet need, rarity, prevention versus cure, using all these additional variables that I've explained before. And I guess what we're most interested in is the top bit that I've highlighted in this tan color and the colored text. And we'll just look at that in more detail. All the panel before, all the other control variables were consistent as before. So here we can see that vaccines has a very large positive effect on the odds of a positive recommendation. The child effect is reduced, but remains statistically significant with the introduction of those other factors. And this is true even when vaccine, TGA orphan, and FDA accelerated access and ATC were all added. So this is column 8 on the page. It remains statistically significant. Okay, and here is some more sensitive analysis where we've used different model specifications. Different model specifications. And you can see in the red rows that the effect of child remains consistently statistically significant and also large. And if I just honing on that top panel, so to go through it a bit more detail, you can see the childhood effect remains across all sensitivity analysis, list with criteria decision, including controls and cost per quality only decisions. And I guess here I'm sharing some potential policy implications, looking at some predicted outcomes. So here I'm looking at the effect of confidence in the evidence presented on the likelihood of child plus adult, and adult submissions of being receiving a positive recommendation from the PBAC. Okay, so if we look at a low confidence scenario where there is considerable uncertainty. There is economic uncertainty, but potentially there is a clinically important difference in the effect size, and let's assume the budget is 20 to 30 million, and I'm predicting this using the primary model for cost utility submissions. Yep. And I guess what you can see is in this low confidence scenario, there's less than 40% chance or probability of being recommended for listing across all populations, but it drops to less than 10% for adults, which is the green line down the bottom that you can see. And then let's look at the flip side where we have a high confidence scenario, again, looking at cost per QALY submissions. Here we have a clinically important difference. There was no considerable clinical or economic uncertainty. Again, I'm predicting using the primary model. And you can see in this high confidence scenario, most evaluations are being recommended at the lower ISA ranges. The effect of the child status is much more pronounced when it gets to the higher ISA bands, with a maximum difference of 40 percentage points in the predicted probability of a positive recommendation when the ISA is between 105 to 200K per additional QALY gained. Okay. And then let's look at another one where the effect of the child and vaccine and the TGA orphan are all combined. And again, I'm looking at a low confidence and a high confidence scenario like before. So and I'm looking at cost per QALY submissions for a vaccine with a TGA orphan status in a child population. And it consistently has much, so this is the solid line, it consistently has a higher probability of receiving a positive recommendation from the PBAC across all ISA ranges. And again, the predicted difference is much bigger at the lower ISA bands when the committee has low confidence, and that moves to the difference sort of broadens out to the higher ISA bands when you're in a high confidence scenario. Okay, so I guess what this tells us is we think the childhood effect is there. And I guess some of the additional ones that I haven't shown you but is in the paper, we've also looked at robustness in subgroups, either by time period, early time period versus late time period. We looked at the different submission types, when there is a major submission, when it's a first submission, when it's a first major submission. We've also looked at the bigger, broader sample, including all submission types, but of course with a reduced set of variables given not all of them would have an ISA reported. And we've also looking at alternative coding for things like when the decision is listed at a lower price, we've coded as both as a recommend and not recommend, and the effect of the child remains stable in all of those subgroup analyses. So I guess in summary, past PBAC decisions suggest drugs for children are more likely to receive a positive recommendation compared to interventions for adults. A positive recommendation is also more likely for submissions for a child plus adult population, but we were only able to show that in a cost per QALY only subset. The effect also persists after controlling for other aspects of equity collinear with age, such as severity, rarity, vaccine, unmet need. And it confirms PBAC's guidance that age is a factor that influences PBAC decision making. So, the paper does have limitations. One limitation is there's a very small sample of child-only submissions, despite including 19 years of data in our analysis. In our primary analysis, we only had 69 child-only submissions. By including the cost minimisation submissions, helped boost our sample size, and we show that it's reliable with some assumptions. The child effect may arise from many motivations, capacity to benefit with productive contribution to society at different life stages, fair innings, vicarious utility for emotive response to saving children, parents, responsibility for others, lifestyle, etc. Some are reflected in rational priority setting, fair innings, proportional shortfall. Others may double count, elements of value captured in the ISA, capacity to benefit. I guess, explicit quantitative weights can provide guardrails to help ensure that the childhood effect is well motivated, and further research is needed to decompose the effect of the child to understand relative contributions of the factors correlated with child status. You know, stated versus revealed, decision makers versus public, what is a socially optimal decision rule. And I guess just an overall conclusion, this is the first reveal preference study to really demonstrate the effect of child status on the likelihood of public funding recommendations for drugs. The large childhood effect remained despite what we threw at it and the analysis, controlling for other factors that may confound the age effect. And the results are qualitatively consistent with what we know from stated preference literature from the general public. It also suggests that decision makers have arrived at a common understanding on how to weight these less quantifiable factors, such as age. And I guess if you want to know more about the paper, here is the paper. It was recently came out, and special thanks, I guess, to Emily Lancer and Kirsten Howard and all the Torch collaborators who involved us in this research. And the project was funded by NHMRC MRFF funding. Thanks.
Thank you, Ching Ching.
Thanks.
Now we'd like to invite a question from the, I think that
Jean-Marc's got his hand up.
Yeah,
Bernie,
so-
can you stop sharing so that we can see everyone? Yeah, thanks. Oh, we can't see everyone anyway, so doesn't matter. Jean-Marc, go ahead. You're on mute, Jean-Marc. Are you able to unmute? And if not, do you want to put your question in the chat? Bernie, are people able to unmute themselves? Oh, people can't unmute, Bernie. Right, that is a problem. Can people type their questions in the chat, please? And Jing Jing, while people are doing that, I just have a question which goes back to the very start. 25% of submissions didn't have economic evaluations. How does that work? You can submit to PBAC without any economic?
Well, it depends because they handle a huge range of applications. There are also what's known as more minor type of applications where perhaps they're just asking for a couple wording change in the listing, or it was an administrative change to add a little bit to the restriction, or it's a biosimilar. So those ones don't typically come with an extensive economic evaluation.
Right.
Yeah.
So it appears people can't unmute, although Bernie, if you can let us know. Otherwise, if people can just please put their questions in the chat, recognising that it's a little challenging, but
yeah, hi Lisa, it seems it's been disabled, so if people can put it in the chat, that would be great.
So while we're waiting for people to putting in the chat, I have another question for Ching Ching. I'm wondering if you could explain why the cost utility seemed to be more likely to be funded in one of the fingers that you show the uncertainty bar.
More likely to be funded.
I think that is on the right, together with child and adult finger.
Let me see which figure. Oh, I see. Yes, that's controlling for everything else. Nuance. So that means there is a benefit. I guess that population, by the nature of it, is funding something that's got a benefit, whereas cost min is minimizing costs. So that will be my interpretation.
Okay, thank you. So do we have
So Jean-Marc, Jean-Marc, do you want to put your question in the chat or walk around to my office and come and ask the question, although I'm not in my normal office? And so, Jingjing, question, it's not, well, there's not weights. You know, they say that they consider age, but there's not weights. Is there then a risk without explicit weights that changes in the committee change how things are, you know, the likelihood of something being listed, you know, with you know, as the PBAC people who sit on PBAC change, the people's own personal, you know, might change what you know, without explicit weights? Like, do you think there should be explicit weights?
Oh, that's a very tough question, Lisa. This is a very prickly question to answer. To be honest, I don't know. I feel there's great benefits to the deliberative decision-making process they've got. So we don't have explicit ISA thresholds, for example, in Australia, in addition to not having, you know, explicit weights for things like age and other factors, but they're definitely considered. I guess that's what our research shows, that it's definitely considered, even though in the guidelines you don't see them as explicit weights or anything like that. So the benefit of a system like this is that it is somewhat more flexible to allow the decision makers to take into account factors that matter. And we know HTA is not really that formulaic. A lot of people think it's very formulaic, but it's actually not, because every case is same but different, and there could be just slightly different things that they need to consider. So I think our system would allow them to consider that without needing to do what the UK has currently done, which is to explicitly say, we're not weighting cancer things or end of life anymore, but we're now doing this severity weighting, or we've got this explicit modifier, they call it, to modify this, and we've got a ISA is this, and then now recently they've just said they're increasing their ISA higher to a higher value. So I think so our system allowed decision makers to take into the contextual factors that they think matters the most in that particular decision without having to calculate formulas or things like that. But I guess that's why I think sometimes the revealed preference work is still really important, because it without it, I guess we wouldn't know in a systematic way whether are they actually doing what they said they would do, and I guess that's what we are verifying. I think it's still useful to know the weights though, but perhaps the decision makers can use it to help their decision making rather than in a formulaic way and use it to calculate anything. So I guess that's my personal view. So I'm not on the committee, so can only say my personal view. Yeah.
I don't know if you can see the chat, Jingjing. Zolmat's put in two questions. So one is, was there any chance to look at the same interventions or the same indications?
I'm not sure what you mean by that. The same indications.
I think he means, so, you know, if the same drug was submitted for children and submitted for adults, I assume that's what that means. But I suppose they would have been submitted as children and adult together.
Yeah, together. That's most common because like if you look at some of the PBAC restrictions, I'm sure you all do that before bedtime. So a lot of the restrictions don't actually specifically say an age, because if you compare that then to the TGA registration, sometimes the TGA is more explicit about the age. You know, they'll say people over the age of 18 were recruited in this trial, and therefore our authorization is for people over this age or that age, whereas the PBAC restrictions sometimes don't go to that length and spell out the exact age. I guess in our research, we were trying to categorize them. So so the ones that Jo might have said, they will be categorized as adult plus child plus adult, because it's together. They don't tend to do two separate ones, one for adult, one for child. Although sometimes it can happen, because sometimes they can submit first for this group and then submit second for this other group. So, but yeah. So I guess, yeah.
And in terms of same indications, did you look at, you know, like, did you look at, for example, the cohort of oncology drugs and go, like, does it, you know, in cancer, is it more likely that the childhood?
Yeah. Yep. Yep. So we controlled using the ATC code. Now that doesn't mean that we're comparing. We're trying to see if it has an effect due to the type of indication it's going for. But it doesn't mean that we've looked at just that subgroup, because we don't have enough within each little pocket of indication to go, okay, we're just going to look at that group. But yes, as much as we can, we try to control for it using the ATC code, which looks at the bodily function affected. So there's far fewer interventions for cancer in a child population compared to, say, anti-infectives, which is a lot more in children. Yeah.
And then Jormat's other question is, how confidently can this study conclude about effects but not associations? I'm not sure what.
Yeah, not sure about this question.
I mean, I suppose you can only look at associations.
I guess we're not causal, is what he's saying. I think that's what he's saying. I don't think this is a causal paper. So we're not saying this causes that or this causes this. So yeah, yeah, he's clarifying. That's what he meant. Yeah, so it's not a causal paper. Yeah.
And can I just ask you, just going back to my other question, are there regions that do have explicit age weights? Are there, countries where their decision-making bodies do have explicit weights?
Not that I'm aware of at this stage. Yeah.
Does anyone have any other questions? I know it takes a while to type in the chat, so maybe also raise your hand if you'd like to ask a question, so we know you'd like to ask a question. That was an amazing presentation, Jingjing. It's an amazing amount of work that's been done with the
I hope
huge
I didn't
amount
go
of
through
data.
too quick. Sometimes I think, I'll just go through it quickly, but yeah.
No, it was fantastic. Are you going to do other things with that data? I mean, there's so much with that database you could look at.
Yeah, we're hoping to. Yeah, we're hoping to.
Bernie, do you just want to share the slides again? And I'll hand over to Nung to...
Yes, so I think that we would appreciate if you could complete the brief post-webinar survey to provide your feedback on the section today, and also let us know what topic you'd like to hear in the future. And I think that the next HEAT webinar will be panel discussion on 13th of May, featuring Professor Emily Lansas, Chief Health Economics at the Department of Health and Aged Care, Dominic Tyden, owner and operator of the Specialist Health Economics and Reimbursement Consultancy, Temus Consultings, and from Professor Stephen Magpie, Director of Australian Centre for Health Service Innovations and Director of the Centre for Healthcare Transformation, Queensland University of Technology. So please join us at the next webinars on 13th of May.
And just with that will be a panel discussion talking about careers in health economics, different pathways, obviously 3 different roles at the moment, but people who've come from very different pathways into their current roles. It will be a panel discussion that will moderate, but if you have questions that you would like asked in that panel, we might, Bernie, when we send around the feedback form, we might, I don't know if it's possible to ask, to say to people, please feel free to email questions that you might like discussed on the panel if people want to talk about different career pathways. And please do obviously invite particularly any, I mean, this is obviously relevant for everyone, but particularly any early career researchers who might want to be aware of different pathways people have taken to get to what are very senior roles now for all three of the members of the panel. So we'd really, really welcome any questions people have, and we'll aim to get the next webinar set up so that people can ask questions during the panel. Bernie, is that possible for people to email questions?
Absolutely.
Fantastic. That's brilliant. So we will send out a registration link for that panel discussion shortly to ask people to register for that. It is at, I can tell people what time it's at if I look in my calendar. It is at 2 p.m. on the 13th of May. So we will send around a registration link, but 2 p.m. Melbourne time, so ST we are at the moment, 2 p.m. On the 13th of May. Bernie, is that the last slide? Do you want to just flick back to the second last slide so that the QR, I was going to just say leave the QR code up. We really do appreciate feedback, and anyone who has any ideas for presentations for webinars, that would be really appreciated. If you've seen someone talk recently that you thought was a fantastic talk that would be of interest to the Actor Heat group, or if you've got some work that you'd love to present to the Actor Heat group, whether to get feedback or whether to have people aware of different methodological advances or other work you've done in the clinical trial space, health economics clinical trial space, please do let us know. You can always email myself and Nung, or you can email Bernie at ACTA, who will send out most of the emails. She will always forward things on to us. So we really appreciate Jingjing's time today, and thank you everyone for attending, and hope to see you all on the 13th of May.
Thanks, everyone.
Thanks,
Bye.
Gigi. Thanks,
Bye.
everyone.
Bye.
Bye.